Pericardial effusion. Pericardial effusion refers to the accumulation of fluid in the pericardial sac. This occurrence may accompany pericarditis, advanced heart failure, metastatic carcinoma, cardiac surgery, trauma, or non-traumatic hemorrhage. The speed of accumulation determines the physiologic importance of the effusion. Because the pericardium stretches, large effusions more than 1000 ml that develop slowly may produce no hemodynamic effects. Smaller effusions that appear rapidly can cause tamponade. Tamponade is characterized by elevated intrapericardial pressure more than 15 mm of mercury, which restricts venous return and ventricular filling. As a result, the stroke volume, the pulse pressure fall, and the heart rate and venous pressure rise. Shock and death may result. Clinical findings. Pericardial effusion may be associated with pain if they occur as a part of acute inflammatory process, or may be painless. As it often the case of neoplastic or uremic diffusion, dyspnea and cough are common, especially with tamponade. Other symptoms may result from the primary disease. Pericardial friction rub may be present even with large effusions. In cardiac tamponade, tachycardia, tachypnea, narrow pulse pressure, and relatively preserved systolic pressure are characteristic. Pulsus paradoxus, a greater than 10 mm of mercury decline in systolic pressure during inspiration due to further impairment of left ventricular filling is a classic finding, but it may be also occur with obstructive lung disease. Central venous pressure is elevated and edema or ascites may be present. These signs favor more chronic process. Diagnostic studies. Chest X-ray can suggest effusion by an enlarged cardiac silhouette with a globular configuration but may appear normal. The ECG often reveals non-specific T wave changes and low QRS voltage. Echocardiography is the primary method for demonstrating pericardial effusion. MRI also demonstrates pericardial fluid and lesions. Diagnostic pericardiocentesis or biopsy is often indicated for microbiologic and cytologic studies. A pericardial biopsy may be performed relatively simply through a small subxiphoid incision. Treatment. Small effusions can be followed by clinically and with the aid of echocardiograms. When tamponade is present, urgent pericardiocentesis is required. Removal of the small amount of fluid often produces immediate hemodynamic benefit, but complete drainage with a catheter is preferable. Continued drainage may be indicated. Additional therapy is determined by the nature of the primary process. Recurrent effusion in neoplastic disease and uremia in particular may require partial pericardectomy. Thank you.